I don't know what to do. It's like, no, but what for? I don't think it make me look like a fool.
So you might want to mute because everybody's hearing you look like a fool. That's
Oh, you know
really
what? I gotta just.
So yeah, if you've got background noise or just aren't talking right now, it probably is a good idea to mute.
Good afternoon.
Good afternoon, Kathleen. Happy to have everybody here. We're still letting people come in, so we're just going to give you another minute or so till we start. If you just joined and you haven't signed in chat, go ahead and please sign in with your name and Health Council, or if you're DOH, what your region is that you represent or what your position is, so we know who's in the room and everybody knows what resources are available if they want to reach out. Still have a few people joining. Let me give them just another minute to get in.
Yay, it let me in this time, Sharon.
Hey, maybe it's going to be a good tech day. I hope. Okay, I have 102 and I still see some people are joining, but I know we have a really packed agenda. So if you just joined and you haven't already put your name and Health Council in the chat, please do that. So if somebody's looking to connect with you, they can know you're here. I'm Sharon Finarelli and serve as the Executive Director of the Alliance of Health Councils. And I want to welcome you all here. Thank you so much for coming. We have a mix of health councils, public health partners, Department of Health, our consultants who are working with this project. And it takes all of us working together to make a difference in the communities we serve. So I just want to tell you how much I appreciate you taking your Monday afternoon when I know you probably have 100 other things you could be doing to prioritize learning how to serve your communities better. And today I want to just focus us a little bit because part of what we ask health councils to do is to be sensitive to what's happening in your communities. And sometimes that means the plans that you had need to change because the environment you're working in has changed. And that's the case with our state. If you've noticed, COVID counts have been steadily over 1,000 for about 2 weeks now. Our healthcare facilities are overloaded. And I think this morning I think there were up to 5 facilities now that were in crisis standards of care. Gerald Champion is the newest one in Otero County. And so because of that, I think if we were to go on as business as usual and not take the opportunity to respond to community needs, that would be pretty tone deaf of the Alliance and of our health councils. And so what I want to do is give us as health councils and public health partners the opportunity to respond to community needs. And that's kind of what we're going to explore today. So what we're doing is focusing tighter on this community need around COVID, around helping to support, promote, coordinate vaccine events, supporting existing systems that are already offering vaccine events and testing events, working with our schools in a deeper way to help to address the 5 to 18-year-old student population that I know some of our health councils are already serving, but some of us haven't really thought about it. And it really takes all of us to meet the needs of our communities. So what we're going to do is shift our focus just a tiny bit more towards meeting those COVID needs in our communities, because our death tolls are going up, our case rates are going up. The impact on community is starting to be felt in a deeper way. So instead of pushing this vaccine equity work that we had hoped to prepare you for gradually by looking at capacity building and have a vaccine equity plan to really begin to work in a deeper way in your community. Originally, we had planned to have that piece around the spring of 2022. We're moving that up because the need is now, and we want to respond to that need. So what we're doing today is going to give you a frame to work within using community-based action planning or community-based participatory research. The research is really about finding out what your community needs and how to work best in your community. It's not really research like you would do in a university. It's really about how do I meet my community needs. So we're going to talk about that framework a little bit today so you have a frame to work within. The Alliance, in the meantime, is going to be working with Department of Health and their logistics team to see how could we work better together? How could health councils plug into the work that Department of Health is doing and serve our communities better by having a more coordinated effort together? We're also working with the NEA, the School-Based Health Clinic Association, and 100% communities who have a focus on vaccine equity and health in their communities to see how do we work with schools better so that we can meet the needs of students and parents who need to be vaccinated, to help people who need boosters now that they're available. We've just changed the whole dynamics of COVID in the past week or two between rising cases, between opening up who can get shots when, and realizing that boosters are really important to make sure that your immunity levels stay high. After we do this piece, what we're going to ask health councils to do is look for opportunities in the counties you serve for how do you connect to what is already happening around vaccine events. How could you help to promote that more? And then later on today, we're going to find out who's already doing this work and how can we learn from other health councils. So the plan for today is first, we talked to you about vaccine or health equity committees last time we met, and we're going to share those results with you. We have a video that kind of reminds us of this, only about 2 minutes, about the impact that is felt more severely in communities of color. We'll have that framework, CBPA or community-based action, however you want to frame it, that really helps you think about how to better serve your community. And then we'll kind of end with some goals about what can we do as health councils, what can you do and in your specific health council, and see how we can mobilize the strength that health councils bring to communities. So I want to take this opportunity now to turn this over to Natalie, who was working with the Health Equity Committee Jamboards last time we met, and give Natalie a chance to share the feedback on equity from Jamboards. Natalie?
I was trying to mute technology. Thank you for giving me the space to actually report out on this findings from Jamboard. And I do want to thank the health councils who engaged in the facilitators from last training session. We did have some really interesting finds, and I think it was a great opportunity for us to begin to open up the dialogue and start to get to know each other a little bit better. in terms of setting up health equity councils and what that might mean for your communities. And I do want you guys to know that this report does, we heard your voice, and we definitely want to make sure that we're keeping that at the focal point of the work as we move forward. So the Health Equity Council training session, as you know, it was held on November 1st, and it did provide an overview of the health equity committees and provide an opportunity to hear from the practitioners in the field, which was you, and also hearing the voice of the community, opportunity to learn and highlight and perhaps co-construct how to move forward. So the presentations, group presentations, sorry, I want to go back. As far as how many health councils were involved, that number is still being calculated because we have to sift through the data to say how many health councils' voice were actually included in the report. But I do know that I would say probably over half of the health council's voice were included in that. So we, of course, we did the small breakout sessions, and we heard from voices from the field. And here's kind of just an overview, a reminder of what we discussed. So the participants, we asked you guys 3 questions, which gave us greater insight to the work that you are already doing. So there are health councils that are already engaged in this health equity work. The resources that were needed to go deeper into the work. So what do we need in order to start to move forward for those individuals who maybe don't have a health equity committee already structured or set up? And then what additional supports you might need in terms of a technical assistance. And so here's sort of the results that we took out some of the ideas that came from the Jamboard session. So in question 1, if you remember, it was what lessons from the field resonated from you? And this was after we had Rio Reba and Bernalillo County share their insights to how they were engaging the equity work. And some things that came out is that equity work is already in progress. So hopefully you all had a chance to really reflect that even from the last presentation and really kind of look at that and say, how are we perhaps already doing the equity work so that it's easier to maybe move forward in that direction, especially now that we're talking about rapid response. Hopefully you have some insight to that. Changes need to happen at all levels, including management, boards, and commissions. I'm not going to go over every single one of them, but just try to put them into something that makes kind of sense. But you guys can go back and read the report yourself. So it seems like people want to be able to have everybody included. So it's an inclusive process, which does speak to equity. And creating an inclusive process around equity and assessment and community needs. So really meeting the community where the needs are and assessing that. And so that was from question 1. Again, you can go back and read the rest of these, but we have a short time, so I'm going to continue on. Question 2, what would you need to have in place in order to build a health equity capacity? And I think this is important because capacity, sometimes we don't, people will say, well, we don't have the capacity. And so what is it that we can do if we looked at it? How can we support in developing the capacity that you perhaps already have or build upon? So time, relationship building, developing trust and buy-in. And I put this because I feel like it really speaks to equity when we talk about developing trust. We know that takes time. We know buy-in takes time, and building relationships really does take time. So how do we engage that? And those are things that will sort of circulate throughout the project. Again, I know that there's this rapid response that's happening, but that doesn't mean that we don't hear your voice and that we're not going to come back to these very important key elements that you guys suggested, which is time and relationship building and trust building. And it does take time. So training around social justice, health equity, community engagement, communications with local leadership. So there was really a need for training around certain things and specifically language. And that, as you know, is being developed. So really looking at it and how do we train in these spaces? Really what we're looking at is getting your voice around, well, what's the need of the community when it comes to social justice? It's not just a one and done. So again, equity at all levels is making sure that we're meeting the needs of the community and not just sort of saying, here's what we think the social justice issue is as a whole. And then building capacity. So again, the capacity in terms of grants and how do we continue the funding, sustainability, I would say, is also a part of that. And so that's something that can be looked at as we move through the process, you know, and as we start to build the health equity committees. And then the question 3 was, what additional supports do you need? Again, we got similar, it's kind of the same question, but really a technical assistance question, but buy-in from the community leaders and the community seemed to be a common thread among all of the health councils. So really, I hear equity in that, buy-in and building trust and getting the leaders on board and getting people to really understand the work that equity brings. Training and addressing power dynamics, communication through social media. Again, training on power dynamics and how do we work through those things, especially when it comes to our leaders in the community and people that are leading certain projects as well. Allow health councils and health equity committees time and space to do the work without pressure from the top. This becomes really important in terms of health equity. And I really want to make sure that you guys understand that we're here to support that process all the way through. As we know, there's like an immediate need, but we're not saying that we're not going to put that at the focal point of we need that time and space to really develop equity work throughout the health equity committees as we move forward. Stakeholder involvement. And so there was a lot of communication around how do we get people involved that are not already involved. It seems to be we circulate in the same circles, we talk to the same individuals. So how do we start to include those individuals that are part of the work already? And so really looking at that, who needs to be at the table to be able to construct a really solid health equity committee that really does speak to the community and engage the community the way that that you guys are wanting to. And then tools, so maybe some policy and some safety support for backlash and technical assistance. And I highlighted this as an importance because, you know, policy and safety, I think is really important. We hear you guys when you say that safety is important to you from backlash and for individuals who may not agree with the mindset or the way that things are moving forward or the policies that are moving forward or what's being asked of you. And I think that that's something that needs to be really looked at because I feel like safety is the most important thing, right? Because we know it's like at the bottom. Once we feel safe within our community, engaging the work, then we can start to feel like we can include other people. So that's important. So kind of the 4 things and final thoughts is there is a ton of great work that's happening in health councils already. We see that the work is already being done and that you guys have model examples of peers who are doing the work, which is awesome. So we can kind of look to them how to move forward with it. There's a need for greater capacity to engage in the work, meaning we need to involve more stakeholders. So how do we begin to do that? There's a need for additional training in multiple areas. And I believe that it would be really critical for us to kind of speak with you guys and figure out where is the need for training the highest and start from that point based on what your responses are. And it's imperative that we work and continue to co-create and be accessible to community in language and structure and strategy. So basically having a language that allows us to engage our communities using the equity lens and using the equity language that makes sense for our communities. So what we will be doing, and I'm gonna wrap up here, this is my information, is we will be reaching out. We're currently working with the tribal health councils right now just to kind of figure out how do we work within that particular community. And we will be reaching out to you guys individually to kind of figure out what are the next steps. And how do we start to construct something that makes sense for you and your community? Now, I know that there's this rapid response that's happening, but we will be mindful of really constructing these health equity committees as we move forward. So kind of coincide or side by side of the urgent need for these rapid response committee that you guys are going to engage in now with this model. So I want you to know that we're here, we hear you, and I appreciate all of the voices that we heard from, and we're going to continue to work side by side with you to make sure that you have all the resources that you need so that you can construct your health equity committees in a very meaningful, strategic way. Thank you.
Come on in. Come on in. Hi, Sean.
Sharon, are you talking? I think you're muted.
Yeah, I just wanted to be sure that you were ready to introduce the video that you were ready to present.
Okay, yes. So thank you, Natalie. I think this is a great segue into creating a space and consciousness around health equity. So good afternoon. If you all don't know who I am, I'm Geraldine Antonio. I am the Alliance's Tribal Liaison. So right now I'm going to share with you a short clip called The Color of COVID. So COVID-19 has exposed the structural racism and injustices that underpin our country and states' health outcomes. We're currently living in a modern day crisis shaped by an age-old inequity. And I think that we know by now that viruses do not discriminate, but the legacy of our bias and racist systems in place set up an environment that makes people of color more vulnerable to the economic and health impacts of COVID-19. So, and I think you'll see that this clip really emphasizes the need for a multi-level approach in how we work, engage, and plan with our key partners and communities. So I think while we're considering how we can help those most impacted, we must remember that once this challenging time has passed and we begin to return to a state of normalcy, the work is not done. And I think our health councils and a lot of the key partners that we work with, that we can just now continue to learn to use what we've learned from the pandemic to help our neighbors and those in our extended communities to address some of these systemic inequities. So before I play the video, I would just like to end by saying that in our journey to healing and restoration, it is important we move inequities and inequalities to the forefront of our conversations and considerations. So I will play the clip now for you all, and I will, let's see, I'm loading it now. Okay, so it's gonna play now.
COVID-19 shook the world to its core, or kicked up a familiar dust, or coughed up what's been resting in the diaphragm of the United States for centuries. Coronavirus broke headlines as a global pandemic, while 2020 was still getting its bearings. You might think, in a time of social distancing, while many of us face an issue that is incapable of discriminating, that we are finally in this together. Yet, there are communities who are more drastically impacted, even by a virus that promises nothing except that it is equally contagious regardless of skin color. Perhaps a virus need not discriminate if the humans it is infecting have created systems that do the discriminating for it. If we are advised that our safest place is inside, then what of the people without an inside? If we must distance from even family, then what of the families who live in no-bedroom apartments stacked on top of each other? If school has moved from classrooms to the kitchen table, then what of the students without kitchen tables?
I had one shift where I saw about 84 patients.
The first 21 days.
Maybe this virus has illuminated an age-old inequity in this country, with mortality rates 6.7 times higher for Black people, 4 times higher for Indigenous folks, 2.5 times higher for Latinx humans, and 2.6 times higher for Asian and Pacific Islanders. Perhaps now is not the time for answers, but for questions. Like, how might we even the playing field? Where are the gaps and needs? Which humans have access to which healthcare? Who can afford to work from home? Why are essential workers being called heroes but not being paid like heroes? What will happen when they are no longer considered essential? What if we acted in solidarity with our most vulnerable? What if Black and Latinx people didn't comprise 56% of the prison population? What if there was no prison to populate? What if no one was disposable and the virus couldn't recycle itself in the imaginations of the rich? And what if we just stopped for a second to consider all the sickness that existed before? To consider how we might start healing those systems? To consider the color of COVID?
So we're going to give you an opportunity to ask some of those questions of each other right now. Madeline's going to divide us into groups. We'll have a chance to process what you've just seen and then come back together as a group and figure out now what. Madeline, do you want to go ahead and break us into groups?
Yes, I'm going to go ahead and open the rooms now.
Hi, Madeline. This is Roberto.
Hello.
I'm with EOH, and I just wanted to let you know that I talked to Sharon about like just kind of being a fly on the wall today in the training.
Uh-huh.
That's why you don't see me on in a work group right now.
Okay.
But yeah, you don't have to be worried about me trying to put me in a work group at the moment.
Okay. Okay, perfect. That sounds good. Thanks for joining us. I see we have a few people left in the main room here. Is anybody having trouble getting into breakout rooms? Clarence, I see you still in the main room here. Just let me know if you need any help getting into the breakout room. Mallory, good afternoon. We're just in breakout rooms right now. Let me know if you want me to add you to a breakout room. Otherwise, we'll be done with breakout rooms in 15 minutes. So I can also have you wait until then to kind of join up with the big group again. We're just discussing a video about COVID inequity. I can maybe send you the link to the video and you could watch that.
Okay, I'm actually on my phone, so I think I'll just go ahead and wait.
Okay, perfect. Sounds good.
Thank you.
Yep. Hello there. We're just doing breakout rooms right now. So participants will be back from the breakout rooms at 1:45. So we can join up with the full group now. What they're doing in the breakout rooms is they're just talking about a video about COVID inequity. So if you want me to send you a link to the video, I'm also able to do that.
Yeah, that would be great. I apologize for being late. We got held over.
Perfect. Yeah, no problem at all. That's not a problem. I'll put the link in the chat here.
Okay, perfect. Thank you.
Yes. And Chris, I see that you just rejoined up here too. Do you want me to put you back in a breakout room?
Can you send me back to room 3, please? I switched
Yes.
over the computer. I had to update and I was like, really now?
Yes,
I should
I'll
have got
add
the
you.
pro version. Thank you.
Yes. Let's see. I think I can. Sorry, just a second. And Joshua, I also see that you just joined up to the main room here. Were you in the meeting before? And would you like me to put you back in a breakout room? Otherwise, if you're just joining, I can give you a little update on where we are as well.
No, I just had another meeting that ended.
Oh, gotcha. Okay, perfect. So what we're doing right now is we're just doing some breakout rooms. I'm talking about a video that that talks about COVID inequity. So if you want, I can send you a link to the video. People will be back from the breakout rooms at 1:45. So I could add you into one, or if you want, you can just watch the video and we'll do a little debrief with everybody at 1:45.
No, that sounds great.
Okay, perfect. I'm just putting the link in the chat here.
Thanks.
Thank you. Yes, I had to go order for Melanie. Thank you.
Hi, Nicole. I see you just joined up with the main room here. Do you need to be connected back into a breakout room?
Actually, I was just barely able to join now.
Okay.
So yeah, whatever you think is best.
Gotcha. Okay. Yep. No worries. I wasn't sure if you were in the meeting and had a technical glitch or if you were just joining up. We're just doing breakout rooms right now, talking about a video that has to do with COVID inequity. So people are going to be back from the rooms at 1:45. If you want to wait to them and till then, and we'll do a little group debrief. But I can send you the link to the video maybe in the meantime, and you can watch it. It's just a couple minutes long.
Okay, that sounds great. Thank you.
Perfect. Yes, I'll put it in the chat.
Okay. Perfect. I got it. Thank you.
Yes.
Oh, welcome back, everybody. I hope you had as great discussion as we did. We had a real difference of opinion from everything from some of the barriers aren't really barriers, that people already know what they need to know and we just need to lay off a little bit. Two, people aren't able to hear our message around COVID if their basic needs are not met. Two, it's hard to get the message through when there aren't communication channels in a really remote rural community. So from your groups, what did you feel like was the most powerful thoughts that could move this work forward? Did anyone have an aha moment or something that was an idea that your health council could approach this difference in communities of color and their impact by COVID in a better way, or in a way at all that you want to share?
To share, Sharon, we had a really good discussion about having wraparound services. So kind of what you were just saying is that if their basic needs aren't being met, they're not, the vaccine's not their top priority. But others have been doing, like food drives and helping with housing or rent or utilities while they're doing a vaccine clinic. And that seems to really get people there, and it's made a difference. And then someone in our group, oh, thank you, Diana. Diana mentioned Medical Reserve Corps. People are struggling to get people to actually administer the vaccines in their communities. But Diana mentioned the Medical Reserve Corps as a help. They could help get people deployed out into your area. And Diana, feel free to talk more about that because I probably didn't do it justice. So.
Sure, I'll copy it into this chat as well. So Bobby McKenzie, dispatches the volunteers that are vetted, insured, and ready to go, and have been doing this for what, a year now. So these folks are not unfamiliar, and they will travel. Some of them are able to get up and go to a remote place for an event. So don't hesitate to reach out to her and ask for what you need, and we'll see if we can fill the need.
So the Medical Reserve Corps is an example of a systems response to a need. And that was another thing that was identified in our group. We had two tribal communities who were incredibly frustrated because the need for children's vaccines between ages 5 to 11 was great, and they were clear on that. And the system did not support their need. There was no access to pediatric vaccines in their communities. And it's frustrating when it's available in the counties, in non-tribal communities, but that's same vaccine is not available to their communities. Did anyone else experience systems problems that weren't being well addressed and could cause some of the inequities in communities of color?
I think we had one of the biggest examples in McKinley County when the city of Gallup decided to impose a lockdown on the city. With less than 24 hours notice to the public and the community surrounding. A lot of families were put out in, getting their needs and their things for about a week there. I think it was when numbers and cases were highest, and, people were just trying to deal and trying to get services and stuff. So it was a really confusing time. But I think the inequity there was that decision makers on the city side and the state side made decisions without consulting with the community or without having plans to meet the needs of those people. They could have easily not only put those roadblocks up with the Peace Corps or the Army Reserve, but they could have also gave out needs. They could have gave out, water and food and cleaning supplies. They just had to mobilize that. And it was only until a couple of weeks later that they did that. But their greatest need was to stop the flow of people rather than figure out why those people were flowing in so much and so readily.
Good point.
I would say that we had kind of a similar experience, not quite as far as that extent, but the city of Socorro put in a mask mandate before many other cities and counties in the area. But kind of the similar thing. It was a top-down approach, and they implemented it with less than 24 hours notice. And a lot of the outlying communities didn't have a way to know that there was mask mandates. So they would drive in from Alamo, Baguita, Magdalena and stuff, and they wouldn't be able to go to the grocery stores because they didn't have masks. So I know our health council, we bought up every single mask that we could in the county and just had them literally at the doors of the grocery stores for that first few days, because people didn't know that there was mask mandates and they didn't have access to masks to actually get groceries. And when you're driving 2+ hours, and gas is limited, that having to turn around is impossible.
Yeah, that's a huge systems problem and not a very expensive one to solve. And then I see Susie's mentioned about partnering with community leaders, because build it and they will come isn't working, that we need to find a way to engage community leaders in the process. Chris Hollis, I see your hand up.
Well, I was just going to try and build a little bit on what Chris and I think it was Samantha both said. From my point of view, and just for everybody else, my name is Chris Hollis, and I'm the health equity specialist now for the Northwest region, the metro area. But I am more of a communication specialist. But when we talk about a systems sort of problem, I mean, I have seen this over and over and over again, and it's almost the way you learn communications. You tend to learn about communications going in a one-way approach always. And over and over throughout COVID, I keep hearing, we need to message better. It's messaging, messaging, messaging. And the way we usually go about this, from the government, from anybody who is the elite, the people who know the things, those of us who are specialists in the area, it's always, we have to get that out to them. We have to, tell them what to do. Those kinds of things. And I think that is a systems approach in terms of communication, especially in public health. We don't do enough of listening to the people we're working with, for example, or as some of you have just said, the leaders don't listen to the community. They don't think about their concerns, their wants, not just their needs, but their wants and other things. And so I think one of the systems problems is this we just tell them, give them the information, do this. It's not about a two-way communication or even more than that. It's just one way. And that is a systems issue.
Our culture of health councils had a similar discussion about how people make change. And we thought, although data is important, they decided that numbers really aren't what makes people change. What makes people have a different approach is usually related to a relationship they have. And so that kind of triggered one of the discussion areas that the group I was with was kind of looking at, well, now what do we do in our health councils? And I think one of the advantages that health councils have is that we have a statewide network in all different kinds of communities. And so we're going to take a break for 5 minutes between 1:55 and 2 o'clock. And what I'd really like you to do is in the chat, share what your community, what your health council is doing to address this COVID inequity. And be sure to put your name in your health council. So if we have a health council who's struggling and you're somebody that's already working with the schools, we need to know that so health councils can help each other be able to reach deeper into communities. And then I agree completely with Chris as far as sending and receiving. We think just because we've sent the message has been received. And sometimes this was another conversation topic in our culture of health meeting, was it last week? We tend to send the message the way we would receive it. So if we are someone that stays on the internet all day, we think it's great if we just email it, or if we just send an announcement, done, message received. If we're someone that likes to use Facebook, we think, oh, just post it to Facebook. Everybody will hear it and get it because that's how I get it. Or we think nobody uses the internet. Not everybody has access. It has to be face-to-face. And so I would agree with Chris that part of knowing our community means understanding how people receive information. And part of that is basic needs. If you're starving, you're probably not thinking much about COVID. You're thinking about where am I going to get my next meal, or I'm dying of thirst. If you're sick, you're thinking about medical care. If your kids don't have clothes to wear, you're probably thinking about that. And COVID takes a really big back seat. And so when we have the opportunity to get to know our community better, we learn better ways to communicate with them. And so as you're sharing, your experience in working through the COVID challenges in your community and some of the things that maybe worked for you, I would just encourage you to think about other health councils that are serving communities that might be similar to yours. And if you find things aren't working in your community or you're struggling, look, ask somebody else who's already doing the work and see if they have some thoughts about things or resources that could be helpful to you. And that was the last thing I'm going to close with before our break is several in our group felt like people didn't know what resources were already there in their communities. And so I'm going to give us a 5-minute break. It's 1:56. We'll come back at 2 o'clock. So really 4-minute break. So go ahead and take care if you need a drink, if you need to stretch, if you need to get your eyes off the screen. Let's go ahead and take a few minutes to do that. Okay, that 5 minutes went fast, actually 4 minutes. So hopefully you got to take care of yourself for a few minutes and are ready to come back, and we're going to change gears. We talked at the beginning about creating a framework for working in your communities, and that is CBPR, community-based participatory research, which is another way of talking about how to plan action in your communities. So I'm going to move to Dr. Nina Wallerstein and Victoria Sanchez from UNM, and have both of these most learned colleagues share what they've learned about working in communities with you.
Thank you, Sharon. And I'm going to start and then turn it over to Victoria, and I'll share my screen and see if it works. So let's see. Oh, God. I'm just being kicked out of my building. We have a Victoria and Madeline, I shared the screen though with you. If they stop whistling, I'll talk for a few minutes, but is it too noisy to hear the whistle behind me?
Oh, it's okay. We can still hear you.
All right. I just want to
but
say
we
that
want you to be safe.
Yeah, so long it's a drill.
it's a regular monthly thing that, of course, I didn't know. They never tell us when. Maybe I'll walk outside and try and do it. How's that? It's crazy. This is like really crazy. Hold on. Unless Victoria, you want to go and I can share that. I can move the screen.
Well, why don't you go outside? Because I think you are best suited to do this first part. But as Nina is moving outside, I just want to thank everybody for being here, but also really to introduce and reinforce the notion that we're offering an applied approach. So it's not necessarily research, but it's community-based action from a participatory planning and implementation perspective. And so what Nina is going to talk to you about initially is much of her life's work. And then I'll talk a little bit about how we're going to make this more concrete. And then we're going to actually end this session with Dr. Laura Patajon coming in and sharing a case example of how she's actually used this implementation framework in a dynamic and fluid way in the COVID environment. So Nina, are you outside? And
so can you hear me? Can
Yes.
people hear me or not?
Yes.
I can't hear you, but can people hear me?
Yes. I'll text you.
Victoria, I better not. You better just do it.
Okay. I don't have the screen though. Let me
Sharon,
bring
can
up.
you hear me?
Yes.
Yes, but Nina, if you want Victoria to take this part, you need to stop sharing your screen and let her share her screen. Go ahead, Victoria. You should be able to share. I just changed the settings.
Okay. It says Nina started sharing her screen. What do you see up there?
So it says multiple participants should be able to share. So you should be able to share without her having to stop.
Okay, well, let's see. As many of you know, I have some of the worst screen sharing options. Okay, can you see that?
Yes.
Okay, so again, happy to be here. I'm going to kind of fill in for Nina and I talking about a CBPR for implementation planning, talking about some of the principles in action. So many of you know that at the Center for Participatory Research, we've been working for many years on designing a way to work for communities to work with academic partnerships. But now we're shifting and we're revising through the culture of health and other work to really focus on work within multiple partnering opportunities. So for those of you who have seen the old definition of CBPR, this may be a little bit different. And we're maybe going to switch to community-based participatory actions as a way to think about our work within this CDC initiative. So we're looking at collaborative efforts between many people, stakeholders, who use and gather research and data. Again, this may not be research, but it is definitely data to build on the strengths and priorities of your communities and to use multi-level strategies to improve health and social equity. So this is a fairly jam-packed definition, but I think if you look at some of the terms, I think it'll resonate with many of the things that we've been talking about and some of the things that I heard even in our small group session. So it's really important for us to think about what are those guiding principles, or how do we want to work within communities and within stakeholder communities and within partnerships. So we really think about communities, and that could be formal communities, informal communities, internet communities, regional communities, geographic, basically how people identify in groups as the best solutions or the best possibilities for solutions. And so I hear that resonate all the time when I listen to the work of our community partners, thinking about how people know what's happening in their community and they know how to work within their own set of actions and within their own histories and contexts. We think of it as a cooperative and co-learning process. We're looking at systems development and local capacity building, a long-term commitment. I mean, people have identified those long-term public health problems, sticky wicket problems, as I call it, that necessitate a long-term commitment to changing these inequities and inadequacies in the system. And then this is balancing research and action. So mostly we'll be working on action, but a lot of the work that we're going to be talking about is really rooted in multiple years of research, understanding how people work together to create local change. And some of you talk about or have thought about cultural practice. We think about cultural humility, where we're actually thinking, and this goes with the co-learning principle, where we are looking at lifelong learning and really engaging and asking ourselves, you know, how we build change within ourselves, but also to facilitate change in our local communities. So this slide comes from Dr. Lisa Kari-Stone through her work with the Community Engagement Core in our Disparity Center, our first Disparity Center. So this is a principle again. We are not working on communities. We're not working necessarily in communities, but through our action and our processes, we want to work with communities. And that's, I think, one of the core principles that we are thinking about. And Nina can speak to this much more than I. This is Paulo Freire, and many of you are familiar with his work and his legacy. And we've been working with this particular concept of praxis for many years. And we will be working with this particular frame as we move forward in some of our trainings in the future. But really what we want to do is go deeply into listening what's happening in communities, have some deep dialogue about why it's happening, what we can do, take action, and come back and reflect on that action to continue moving forward. That is probably the most simplistic explanation that you're going to hear of Freirean praxis, but I want to make sure that we can move forward with our practice session today and make this as concrete as possible. So for those of you who have not seen this CBPR conceptual model, please don't get overwhelmed. It is a model that's built on many years, well over a decade of research. And so these are components of this more complex model that some of us work with more intensely. I'm not going to go into any details, but to think about this idea of context. So what's the health issue of importance? Right now, it's this uptick in COVID rates in the state. And so the context that surrounds it are some of the things that we were talking about through the video that we were just watching. So what are the social and structural elements that bring to bear all of the inequities around COVID rates? What's been the history of collaboration, and what's the issue of trust and mistrust? Natalie brought the importance of trust and trusting relationships and really listening to communities. And this is really an important piece of the context. When we're thinking about partnering processes, what's that idea of relationship building? Relationship building is founded on trust and many other aspects. This box here, intervention and research, I'm not going to go into detail because what I think we could really rename that box is an action box, and I'll go through that in a minute. And then these outcomes from our research, there's intermediate and long-term outcomes. And again, because I want to focus on some very concrete ways to apply the model, I'm not going to go into much of this right now, but to just kind of break it down into these 4 domains. So we have context, we have partnerships, we have actions, and we really want to stay in the action frame, and we have health and social justice outcomes. So as we were thinking about the CBPR model or the CBPA model with the CDC initiative, I just wanted to reinforce the notion of context in the sense of really recognizing, the importance of local context. What's happening in your communities? Do you not have enough staffing to actually do COVID testing? Do you have issues of poverty that are really taking over and really becoming much more apparent in the COVID epidemic? What's happening within your local context? What kinds of local data do you have to help you understand what's happening? And Susan, well, I guess CHI will be working with you much more on local data as well as the Department of Health. When we think about partnerships, we think about partnerships and a corresponding idea of stakeholders. Anne Egan will be speaking much more to you about the importance and stakeholder engagement in future trainings. But right now, I just wanted to underscore that we're talking about partnerships between the health councils, within the health councils as coalitions, a partnership with the health councils and the public health division, with UNM, with other academic institutions, and with many other local and statewide stakeholders. So again, partnerships are not the same. Partnerships aren't equivalent to stakeholders, but they are really complementary concepts within this idea, an ideal of community change processes. This next box, again, is the action box. So we want to look at what are the common planning and action and evaluation strategies that we can participate in over the next couple of months. And I italicized the word action because as Sharon started this whole session, we are in the middle of a huge COVID uptick again. And it's really an opportunity for health councils to convene around this particular emergency that we're facing. And then again, we're looking at systems outcomes as well as statewide shared outcomes. And when I'm talking outcomes, I don't necessarily mean these huge outcomes, but really what are some of the goals that we have in terms of short term and longer term. So we have an opportunity to use this model in multiple settings. It's just not for research projects. We can use the context, we can use these domains of context, partnering, actions, and outcomes in small, medium, and larger initiatives and in multiple settings, and we can use them in varying timeframes. So for right now, we're going to be really focused on a 2-month timeframe in our work together today. And again, to reinforce the notion of stakeholder engagement, when we're thinking of who might be at the table and who might be missing, these are some of the things that we may want to think about as we're thinking about your health council and who's participating. So we're going to spend a few minutes talking about, in groups, talking about using this model in an active way over the next couple of months. So this box here, we have vaccine equity outcomes and health council actions. And what we'd like you to think about is an outcome that's related to vaccine uptake over the next couple of months, and then an outcome that's related to equity. That can be a longer term outcome if you'd like that to be, or think of it as a goal if that makes it easier. So we're going to break out into 4 rooms by region. So it'll be the Metro and the Northwest region together, the Northeast together, the councils in the Northeast region together, Southeast and Southwest. And so I think you have really been getting ready for this particular activity since we started today. So what we'd like you to do, and I know you're going to be in your health council regions, and so this won't be necessarily individual health council action, but what I'd like you to do is start thinking about what are some of those vaccine equity outcomes that you would like to see in your council or within your region. And you can start, let me go back here. You can start with the vaccine uptake outcome or an equity outcome. So identify a couple of outcomes. Then we'd like you to pick one of those outcomes. And again, I just want to reinforce this is practice. I want you to pick one of those outcomes as a group. So you're here. And then I want you to go here and brainstorm some actions that'll help you get to that outcome. So I can't see anybody's face, so I'm just kind of talking to my own screen right now. So then brainstorm together some of those actions. And then in the last 5 minutes or so, I'd really like us to get to maybe identifying a couple of actions that might work over the next 2 months. So I think the thing to remember is that this is practice. We're doing this by region, and we will be working with you so that you can do this within your individual health councils. So when you go back to your health council, you'll be able to go through this process, hopefully together, whether it's in your equity committees or in your whole health council, to look at specific outcomes, to choose one, to brainstorm actions, and then to actually pick actions that you can do in the next 2 months. So by the end of January 22, this is probably your one of the biggest activities that we're going to ask you to do. So I'm going to stop there and stop share. And hopefully I will be able to see.
All right, I'm gonna go ahead and open the breakout rooms if that's okay. Everybody's gonna have to go into the breakout room based on their region. Go
Madeline?
ahead, Victoria.
Yes.
Before you do that, I just posted in the chat the links to the Jamboard. Please select your region's Jamboard, and then we'll go into breakout rooms. Sorry to interrupt you, Madeline.
No worries.
Yeah, so everybody knows what region they're in, right?
And if you have any questions, I'll be in the main room and I can help you get connected with the right region as well if you're having technical difficulties. But there should be a breakout rooms box on the bottom of your toolbar in just a minute here, and you should just be able to click right on that and choose your region. I'll open the room now, and if anybody's having any
hold
issues.
on. Madeline, 1 second. So if you have any questions, I think Madeline will post her cell phone in the chat box. So if you don't have that, you might want to take that. And what we're going to do is we don't have a lot of time, but we're going to come back. We have very little time. So we're going to come back in about 10 minutes, and Laura Patajon will join us then. And she'll provide a specific example of how we can use this framework. Okay. So again, just click on your region and we'll all see you there.
Madeline, this is Ophelia. I clicked on the region. I see the chat or the Jamboard, but I'm still
Yes.
here.
Yes, so you'll wanna, the Jamboard and the breakout room are two separate things and you'll have to click on both of them. So you'll also want to click on the breakout rooms button. And if you look at your Zoom screen in the bottom toolbar where you see like your mute and your stop video and your chat things, there should be a little box for breakout rooms and you'll want to click on that and then choose the breakout room associated with your region.
I don't see any. Maybe it's under more breakout
Yes,
rooms.
it may be under more. Yes.
And then you click on your region?
Yes.
Okay.
It's Rosalie. It doesn't let me. It says that I have to download the Jamboard.
Okay.
So I might be a little late.
That's okay. And you don't have to worry too much about the Jamboard. If you're able to join the breakout room, you should be able to see the Jamboard in there too. I think the facilitator should be able to share their screen or something like that. So
okay.
If you are able to figure out that piece in the bottom toolbar, you may have to click on the little three dots that say more in the bottom bar of your Zoom screen to get to the breakout rooms, but then you can just choose the room associated with your region.
Okay, I'll try again. Thank you.
Yes.
I seem to be having the same problem. I can't get to that breakout room. I just get pin and
Me too. I just get
a rename. That's all I'm getting.
Yeah, I got to the breakout room easy earlier, but now I'm not finding.
Okay, yeah, so these
Okay,
ones
there
are
they
set up
are.
a little differently than the ones before. So if you see in the bottom, the black toolbar of your Zoom screen, there's a bunch of little things. There's like the chat button, and then there's three little dots that say more. If you click on breakout rooms, then what happens?
I get a blank white screen that says breakout rooms in progress, but there's no options. For a little while, it looked like I could see names and regions, and then it disappeared.
Okay. Well, I guess the other option is I think I can assign people to breakout rooms if there's anybody left over. Let me just, if there's people that are having trouble with it, perhaps we can do that. This is Joanne? Or there's a few people. Okay. So I'll go down kind of the list here. Holly, remind me which region that you're associated with?
Southwest.
Okay, perfect. I'll send you there.
Thank you.
Rosalie?
Yes.
Northeast.
Northeast. All right.
Yes.
Yes, I need to get to Rosie. This is Rhonda.
Hello.
Hi, I need to get to Northeast, Nambe, Santa Fe.
All
Is
right.
that Northeast, right?
Perfect. Yes, that sounds right to me. I will send you.
Okay, I can't
to
get into the link. Thank
Northeast.
you.
Yes, thank you. For people remaining, can I get you sent to the right breakout rooms here?
Tom, could you send me to Northwest, Madeline?
Yes.
Thank you.
You're welcome.
Hi, this is Becky. Can you send me the Northwest region, please?
Yes.
Hi, this is Cam from Los Alamos. I'm not sure what region we're in. Do you know?
I should be able to pull up a map here. Let me just check. Let's see. Los Alamos, it looks like you're in the Northeast region. So I'll send you to the Northeast region, Cam.
Okay, thank you.
Yes. Let's see. Okay, I'm seeing a few names left on here. Is it okay if I kind of, let's see, I have Joanne Palomino here. Do you know which region your health council is associated? Or if you know your health council, I can look it up by that too. If there's anybody else that needs help getting associated with their correct breakout room, just let me know and I can direct you that way.
I am sorry, this is Laura, and I had somebody scheduled something else that I have to attend, so I'm going to have to drop out. So please give my regards to Dr. Pardajon.
Okay, thank you.
Okay, well, we're all back, and as much as we try to avoid Zoom problems, maybe we'll never totally get rid of Zoom problems. That would be an outcome for me. But I hope that this even brief session allowed you to think about in more concrete ways what you can do within your health councils in the next couple of months, but also within the context of this larger vision of how to introduce issues of equity and within your councils. So I don't know if Dr. Parajon is here yet. Nina, is Laura here yet?
I just checked and don't see her listed in the participants list. So maybe not.
Okay. So while we're waiting for Laura, does anybody want to share with us any particular outcome or actions that you were able to define within your regional groups?
I can share from our group. So we were Southeast, and Southeast has a pretty good communication system they're already using, but they felt like what they really could do that would make an impact is to have more vaccination events. And part of the problem that they saw around this was correcting misinformation in the community so that they might be willing to participate in vaccination events. They felt like ways to do that were to get community leaders to share accurate information. And they also felt like TikTok would be a real key to engaging youth in the vaccinations for school-age children. And so in the next 2 months, they felt like it would be possible to have an event, possibly have a co-county event, like if they were having trouble getting enough people attending the events to make it really, seem worthwhile. So Jennifer suggested, maybe they could go in partnership with their neighboring county. So we had both counties promoting the event, and it was, at the edge of both counties, so it was accessible. That maybe that might help. But they also felt like they really needed to learn TikTok because that was a communication tool for younger people that wasn't being used.
Okay, great. Very, very specific action steps that sounds like they're very doable for sure. Did anybody else come up with similar action steps or similar populations to work with?
Victoria, sorry to interrupt. This is Roberto. Dr. Laura is texting me saying that she, for some reason, is having some technical issues with her calendar invite. Could someone resend her invite to the DOH address by any chance?
Yes. Thank you, Roberto. Madeline, could you do that? Thank you.
Our group had a lot of incredibly specific strategies that worked, and the outcome is really to be able to increase vaccine uptake and increase the partnerships in communities that are involved, and strategies that were everything from community outreach and information dissemination and sharing using multiple platforms to having conversations, really looking at engaging all of the stakeholders that really represent the community in the Health Equity Committee so that people who are in different groups can help the Health Council understand how to message and how to communicate to groups, particularly that may be having some challenges or difficulties. And great. Folks in that group, please add to it because there was a tremendous amount of great information that was shared.
Yeah. Thank you, Anne. I want to say that we want to share these Jamboards across the state so that you all have the advantage of seeing other ideas and building and learning from each other, because I think that's an important thing that we do here. And Geraldine, do you want to report back since you were taking a lot of notes for our group?
Yes, so there was discussion around more regional collaboration, and that including working with some of our tribal communities. And I think part of that is opening the invitation to meetings and trying to introduce the work that's happening in their region. And then also we had another outcome of vaccinating the youth. So part of that was dispelling some of the myths around the vaccine, improving some of those communication methods, and then also looking at identifying and collaborating with trusted sources through listening sessions And then kind of explaining those vaccine access, explaining that a little bit further. And also, again, comes back to trying to host those listening sessions for the communities.
Okay, and I just got the news that Laura is here, and I'm sorry we won't be able to hear from everybody, but let's go ahead and hear from Dr. Parajon, who's using this as a dynamic model. The CBPR model is dynamic. Welcome, Laura.
Hello, hi.
Hi.
Can you see me?
Yes.
Okay. Oh, you can. Okay, great.
Yes.
Hi, how are you? And I can share my screen, I think. Hi, everybody. I'm sorry I wasn't able to attend the whole activity, but Victoria and Nina wanted to see if I could just kind of share how we use the model and kind of a lot of things that we do and just how it could be used. So sorry, this isn't like the best presentation, but I think we can just try to use it to see how to put it into action. I had an original one that was for the work we did in the shelters, but I thought I'd try to make one that, but I didn't have as much time as I wanted to do to kind of see how you can use the model. So I'll just give a little context of how we use that community-based participatory action model as a framework for everything we kind of do. Can you guys see the screen? And
Yes.
So, okay, great. So basically, you know, the Department of Health has recently updated our mission and vision. I don't know where it went, but it has equity as a huge component and partnership as the key. So for the COVID response, we're trying to figure out, like, can we do better with equity? And I'm just going to use the vaccine response. So contextually, if you look at this data, this is the data. I'm just going to take one group that has had a particularly low vaccination rate, and that's Hispanic and Latino populations. Actually, Native American populations and Asian American populations have done really great. The two populations that have the lowest rate is Hispanic, Latino, and African American, but we don't have such a high number of African Americans, so we'll just focus on this. So here's when we got the vaccine, and then here's the cases every week by race, ethnicity. So you can see that over time, like Hispanic and Latino cases have gone down, but still remain the highest group even today. You can see Native American had a huge amount of cases initially at the beginning of the pandemic, but has stayed down low, has recently gone a slight increase in cases. But if you look then at hospitalization, though, you can see also the same pattern for Hispanic, Latino populations, that they're still the group that's most highly hospitalized. And then this, you can see that hospitalization and ICU level by poverty level is also increases, you know, based on the more higher level of poverty you are, the more likely you are to be hospitalized or placed in an ICU. So these are some issues that we were thinking of as what is our equity outcome, is that we wanted to address you know, the situation that right now, especially this is so important right now, we are in crisis standards of care. Our hospital is completely full of patients. We can't even move patients in the ICU. So there's a lack of beds and hospital staff. You know, COVID hospitalizations, like basically what we're seeing right now is that, let's say you get a heart attack or have a stroke, nothing to do with COVID, there's still not enough beds or ICUs available for you. And you could potentially not survive, like this man from Oklahoma, because there aren't enough beds. And then COVID, so these COVID hospitalizations are actually affecting the rest of the hospital system. So we're looking at how to address this situation that we have a Delta variant that's super, super infectious. It's infecting, instead of every 2 people, it's infecting 5 to 6 people. If you look at New Mexico, we're completely have a high transmission in every single part of the state. And then our cases keep going up. So looking at the CBPR model, given this context, you can actually think about it like, what's our health and social justice outcome if certain groups are being disproportionately affected? and like people with high social vulnerability are affected. So the way we look at it is just thinking about, you know, how do we start with the outcomes? And so one of the outcomes that we cared about a lot was, you know, certain outcomes like, sorry, I don't know where. So we cared about certain outcomes like programmatically, we wanted to see that we had higher rates of Hispanic and Latino doses given than what we had before. So looking at how do you like look at how we do the whole thing. I don't see where we, so that's the context, right? So the first thing is you look at the context. So our context is really poor right now. We have a disproportionate number of Hispanic and Latino populations being hospitalized. And then we have actually low rates of Hispanic Latino vaccinations. So they're the lowest group for vaccination. So that's our context. And then partnering practices is how we looked at this initially. So we're looking at how do we do different practices to assure like how are we working together. So at the Department of Health, we actually, when we started seeing that there was a lower rate of Hispanic and Latino vaccinations, as well as African-American vaccinations, we actually looked to our partners. So we got community health workers, community members, community partners like community-based organizations and faith-based organizations as a group to work with us. We work with community hospitals and clinics, universities and foundations to get some funding, and nonprofits as a sustainable partnership model, right? And then we looked at who we had in the Department of Health and also state health departments. So looking at Department of Health, the FEMA, National Guard, CDC, different organizations to say who was at the table and how do we get them at the table to actually reach our goal of increasing Hispanic and Latino vaccine rates. So one of the things that was really important was we have Roberto Martinez here is our health equity director. So he really worked with different partners and I think some of you here on the call to really fosters trust, do a series of things we did with community health workers, reaching out into the community to listen to the community and get the information regarding how was the vaccine rollout going? Was it reaching the Hispanic Latino populations that we were seeing that we had a very low rate of vaccine rates? Trying to have like meetings where we could just have safe spaces with the community health workers to get their information and like really facilitating reflection and dialogue. So that was kind of some of the stuff that we did for partnering. And then this is the programmatic piece. So we knew that if we could do good partnering practice and like looking at our context, so like the data and who are our partners, we could hopefully do a better program. So this was kind of the what we did for Hispanic and Latino low vaccination rates was to really prioritize scheduling for high SVI zip codes. So we initially looked at like how could we improve you know, areas that were in poverty zones to like pull them into the vaccines. We also placed our, we had mobile teams. So we also placed them in high SVI zones. We also did this rapid community assessment. It was called the River of COVID Vaccination. So we actually looked at, met with community partners about what were the barriers, you know, and we made like a little river. So it was like funner, you know, to communities like, you know, I didn't hear about registration opportunities. They were worried about side effects, losing work. There were language barriers. They were concerned about the registration. So we did different things based on these barriers and based on their solutions. So communities said, could you do more registration help? Could you have more hotline, you know, let people know that the cost is free, have more workplace vaccine sites. So those are a lot of things we did in our vaccine work was to say, okay, so this is the context. We have all these partners. Let's pull them in together to develop a program. So here was our equity plan, where we really looked at how do we assure that we can operationalize and, you know, the low people who've been disproportionately affected. And you can see that if you look at Hispanic populations here, when we implemented the equity plan, you can see that slowly the Hispanic population doses went up. So we were monitoring this over time. And we have data on the DOH website so that in your county, you know, as a health council, if you look at it, you can see, you know, if something is improving in your county. So that's data that we have for you guys that we developed. We also, you know, the more we identified the barriers and then set the objectives, our team actually set an objective of, let's try to see if we can increase uptake. And we did this for actually Hispanic, Latino, and African-American population, but I'm just showing you one of the groups. You know, we did mobile teams with extended hours, walk-ins. We did co-development of the educational materials based on surveys, and then we keep on looking at the data to see if we were improving over time. So this is just an example. I don't know if any of you guys went to the FEMA mobile team unit, but they were basically placed in different high zip code zones with high social vulnerability index, which is like the index that shows, you know, your vulnerable population. And then we tracked the data. So we went to see, like, did it increase zip code area people? Like when we placed the vaccine in the zip code area zones, did you increase improving racial and ethnic equity? We did improvements to the communication materials. So it'd say free, no need for ID, no need for insurance, and then put pictures of different racial and ethnic groups. And the call center, actually, we made it so that you can now register and schedule people for people who are calling online. And we made it from 8 a.m. to 8 p.m. so people could get access to it. And then we'd look at the data again and say, okay, good, you know, guess what? When we had the J&J pause, then we had a whole drop off of, you know, Hispanic and Latino doses. So like, what could we do to improve it again? So then we said, okay, let's go back to the community and get more messaging and see what was concerning to them. So we developed a COVID vaccine flip chart that actually is divided up by like different facts and concerns that people had. And then we used Gabe Sanchez. He had a survey that showed like, what are the most effective messages? And then we worked with community health workers to change messaging so that, you know, here was the original one, and it had one of our interns who was white. They're like, we don't want the white intern. We love her, but we don't want her. So they changed it so it's a Hispanic and Latino picture better. So we did that. People were concerned about blood clots and J&J. So we developed some flip charts around the blood clots. And these are actually, we have these flip charts, so you can get them if you want. We actually can send them to you if you want. But it's like, do vaccines cause blood clots? And one of our interns thought it was a great one, that you're more likely to be killed by a meteorite than get a blood clot from COVID. But a lot of our community health workers said that seemed like really belittling their concern. So we changed it to be like, this is your chance of actually getting COVID, you know. We developed a community resource center. So here's a get the facts so that people can easily get to registration, COVID testing, antibodies, flyers, the flyers you see, flip charts, so that we can get the information out more to people just in one place. We know we have to do a lot more, but that's kind of how we're trying to work, right? You know, here's the progress for the state. Actually, we're at 73% now. This was a earlier version. Here you can see vaccine for Hispanic, Latino. It's still low, you know, but we're working to slowly improve. And then this is for 12 to 15-year-old doses. Hispanic, Latino is still low, but we're trying to use this information so that you can, you know, figure out how to help people get a vaccine. Or really, I mean, at the end of the day, this crisis we're having, people are going to probably, you know, die unnecessarily because our hospitals are full. You know, this is driven primarily like by people who aren't vaccinated right now. And so we're hoping that, you know, you can use this model to like analyze your context and see what's the situation you have, who are the partners that you have available to work with, then developing programs that you are developing with your community, and then have the social justice outcome, which is try to help people who have been disproportionately affected. So sorry, this is like a really short little explanation of how you can use the model. But I think that it's easy to use. It gives you kind of a model that you can use. And then, through the DOH, we're super willing and excited to support you. And, if you need a mobile team, reach out to us. If you need educational materials, reach out to us, because a lot of this is misinformation, that people are getting. And yeah, so anyways, that's just a little brief explanation. I hope that was helpful.
That was great. Thank you, Dr. Laura. So for health councils who felt just a little overwhelmed thinking, how am I going to do all that she just showed me? Let me just bring you back to the tools you have today. So after today's meeting, you'll have the little 2-minute video that might be a good way to introduce the impact of COVID in communities of color. You'll have the PowerPoint that talks about the community-based action model that Dr. Laura just showed you, so that you might be able to use to explain a way of thinking to your health council. You have the Jamboard, and you'll have samples of that in case you want to use that as a tool to decide on an outcome that your community wants to focus on and an action that you could take within the next 2 months. You have access to the flip charts if you have concerns about misinformation. And there's also some upcoming trainings that will happen even between now and our next training. On the 16th, you should have, if you haven't already, you'll receive again communication from Madeline from the Alliance. The Santa Fe Community Foundation will be presenting a training on community engagement that may be helpful to you. It's at no cost. On the 19th, which is this Friday, Health Council Talks will be about, well, it's going to be about the Tularosa downwinders, but also we'll have Department of Health's communication person, Katie Diffendorfer, sharing some information about communications from DOH and how we can communicate and work better together with DOH. And then on December 6th, we're going to have Susan Wilker and Joan Appel from CHI talk about vaccine equity planning in your community and data dashboards that are available that Community Data Collaborative is putting together for each of our counties. Excuse me. So there's a lot of opportunities. And if you're a little health council, you can start with just the video and maybe just talking about how do we think about what to do in our communities. So you can start with wherever you are in your health council. If you need help, contact me or Susie. We can put you in touch with consultants, Department of Health, to help meet your needs. And then before we leave, we have 2 more pieces of business. I want to let Madeline talk to you a little bit about what's happening to try to help our Zoom experience be a little bit better. We've noticed that we have multiple Zoom links out there. And Madeline, do you want to explain what we need to do to manage that better?
Yes, I do. Thank you so much. Basically, I just want to give everybody an update that we're going to be updating our calendar invites and also our Zoom links for all of our upcoming trainings in order to reduce confusion, create consistency, and also respect the privacy of all of our attendees. So please watch out for updates with the new training links in our NMAHC announcements listserv. And if you're not subscribed to that, or if you're not getting updates about that, I'm going to post the link in the chat where you can go to subscribe. I'm also going to add this link to the meeting minutes for today, but we also use this listserv to share a lot of other information. For example, the recordings for our trainings and like the meeting minutes and resources and everything for health councils. So we really want to get you connected with this listserv. So if you're not subscribed, or if you are subscribed and it's maybe it might be going to like a spam folder or promotions folder or something like that, But if you're having issues with it, contact me and we'll try to work that out, because we really want to make sure that everybody's getting all of the information about all of our trainings and our recordings and all the follow-up information that you need to kind of do your work. And so, yes, just a final clarification, you can go ahead and remove all of the existing Zoom links and calendar invites from the Alliance for our upcoming trainings, like this training and also for our Health Council talks. And on Wednesday, we'll be sending out new training links in the NMAHC announcements listserv, and that will have all the information that you need for all of our upcoming trainings.
Okay, so just to review, you have tools to use with your Health Council. We are improving your Zoom experience to use a single link. And so if you already have calendar invitations on your calendars, you might want to remove them and make sure you have the new links, which will be one link for everything. And then the last thing is around reporting. We've had a lot of questions around people who haven't received their contracts yet for this project, and how do they keep track of reporting, and should they wait or should they go ahead and report? So here's the deal. We've heard a lot about marketing and sharing information about what's happening in communities. We use those reports to do that work, to help health councils connect to each other, connect to resources, help us to share the great work that you're doing. So your reporting is a lot more important than just saying we should pay you because you're doing work. This is really to help support health councils and to help share the great things you're doing. So even if you don't have your contract fully executed yet, please do report. And Susie's going to put the link to the reporting for the October work that your health council has done in the chat. And so if you go ahead and submit the report when your contract is executed, you'll still be able to invoice for that. And it will help keep straight between what you did in October, what you did in November. Also, I love being on your health council's email list. I don't get to come to all the meetings, but I read all the minutes and I read all the agendas, and that helps me know what health councils are doing. And it's almost like a report to me. So if I'm not on your list, would you please add me? Because I want to make sure that we stay in touch with what your needs are, what you're doing. I want to brag about you because I think it's amazing when I see what some of our counties are doing, the work that you're doing around COVID, the work that you're doing around social determinants of health, the work that you're doing to collaborate with each other. And I noticed you don't talk about that a whole lot. And it's really something worth talking about. So I want to talk on your behalf. So please do share. We have 2 minutes left. Anything anybody else wants to share before we leave? Okay,
hey,
so
Enrique.
go ahead, Enrique.
Yeah, I just put in a link. There's a local musician who earlier this year wrote a song about getting the vaccine. And so
cool.
I put
We'll
that in
send
there. We put it on
out to
our,
everybody too. Yeah.
put it on the front page of our website and send it out on our emails. So
Great. What's your web address in case somebody wants to take a look at it, your website?
okay, let me find it. It's easier to copy than to say it.
Okay. All right. Yeah. Anybody else? You got lots of resources in this chat I'm looking at.
I put my email in the chat because I would also like to be included in the listservs of the health councils if you haven't done so already. So thank you.
What a great group. Thank you all for being here today. Thank you for sharing your experiences. We'll share that out with all health councils. Thank you, Dr. Patahone, for sharing your experience with Department of Health, and for Nina and Victoria for giving us the overview of CBPR, for Geraldine for finding that amazing video. That's a great conversation starter. What a great experience. I hope we all feel energized and ready to take on our community needs when we leave. So we'll see you the 16th if you're attending Santa Fe Community Foundation's Community Engagement Webinar. If not, we hope to see you at Health Council Talks on Friday at noon. Take care, everybody.
Bye.